The Sinski is under the flap, not under the channel. And that's what we don't want. Now I'm going to show the case. So that doesn't mean that we're done. I just want to impose that when you're starting with CTAK, sometimes patients don't even tell you they had LASIK. And sometimes it's a surprise even that you're under a flap. So we just created a new surgical plan. We had a new entry point and created a new plan for this patient. And we utilized OCT to look where that flap was. And this was a patient who had LASIK back in the early days, and it was more than 200 microns. It was a very thick LASIK flap, very early on of LASIK. So I'll show the case here. You're gonna see here that we started off, we're making our incisions, we're opening the channel, we think we're in good shape, and then you're gonna see here, right there, oh, and you notice you're under the flap, all right? Of course, at this point, I'm like still looking, going, am I under the flap? Am I under the flap? I was under the flap. So we stopped. We positioned the flap back down and we made sure that everything was fine. It was a nice position and we stopped there. 2 months later, we come back with a new surgical plan with incisions in different places. What you'll notice, if you don't open that channel, it just seals right back down. And even if you're doing laser and then you wait 2 or 3 weeks to open the channel, that channel is closed. You have to remake it. So if you're going to do sequential laser and then actual do the channels, you want to open that channel first and then give it a week or so. But if you don't open the channel right then, it's going to seal back down. So we created a new plan with a 400 micron channel. So we went deeper than the LASIK flap. And we insert the tissue in the deeper channel, and it worked beautifully. And this patient had a really nice recovery. And I'm really happy we didn't give up on this patient. We thought about it, we talked to the patient, we said, maybe this isn't a good idea. We don't know exactly if we're gonna be able to do this. Patient was very persistent. They wanted improvement. The acacia on this patient was very severe. They wanted to have improvement, and we were able to obtain that with a new plan, a new thing. And CorneaGen is really good, not just because I'm at the podium, they're really good about thinking through what could be a good plan for this patient, how can we revise it to improve things. So just an example of something that didn't go well, but we were able to modify and improve it. So I want to present some cases here. And these are cases now that we've started to think out of the box of what can we do with CTAK for these patients. So why can't we do other procedures for visual recovery in patients with keratoconus? And it seems kind of logical, but I'm not sure how often we do these things. So I'm going to present cases with combined modalities, CTAK with other things. So this is a patient who desired visual improvement and freedom from glasses. Of course, when the keratoconic comes in for a refractive evaluation, usually they walk away with their head down because they're offered nothing. So we've stopped doing that. We talk about, well, what can we do to get you to where you want to be? So this is a patient with keratoconus. This is their scans. All right, you can see the nice cone in the center there. And we did the procedure. They still have astigmatism, but it's a little bit more regular astigmatism. So then we go ahead and they had about 15 diopters of flattening of their cornea. We gave it about 3 months, and we went ahead and did an ICL procedure. So it's not any different than our typical ICLs that we do, but when you have a patient with keratoconus and we can offer them that vision correction, so we were able to give them 20/30 vision in this eye that initially had a ton of astigmatism and a ton of ectasia. So nothing really different about our process. You want to be, of course, careful not to go into the tunnel of the CTAK, but it doesn't really change your procedure dramatically. And the tissue, the ICL fits snug as it always does with these procedures. And we mark our astigmatism. It's very stable in the sulcus. And patient has a really, really nice result. And again, you have this patient who's 20/20 with keratoconus, and you can just imagine the kind of the joy that the patient can have. So some more examples. So this is a patient who had CTAK, or this is a patient who was pseudophakic. So the patient had cataract surgery in both eyes. We gave up on the eye that was severely keratoconic. We basically said, you're about a -17 post-cataract surgery with a very low diopter IOL. And we kind of just gave up on this patient and said, there's not much we can do. So it was about 3 years prior to us starting to do CTAK. And I would give credit to my optometrist who was seeing the patient, who said, hey, John, I think we can do something for this patient now. What do you think? So we went ahead and talked to the patient, and the patient was on board. 70-year-old, very active lady, She's like, I'm on board. So we went ahead and did her CTAK in her right eye that has a -17 diopter. And this is her cornea changes. And the improvement was dramatic. She had 6 diopters of flattening, and her uncorrected visual acuity went from count fingers to 2200. This is with CTAK, this is a great result. This is a happy patient who had some functional improvement. But we said, is there more that we can do for this patient who's now a -11? So we went ahead and did an ICL under her CTAK, but above her pseudophakic lens, and placed an ICL segment in the sulcus space. And again, with a patient that is a -11, it's a very reasonable way to piggyback an ICL for this patient. So you'll see here, we do our ICL procedure. Again, nothing too exciting happens here, thank God. It's just something that you can do now for these keratoconic patients, involve multiple modalities. So we're gonna insert the ICL above the IOL and place it, and this is a toric ICL fitting in the sulcus. With the sizing of these, usually you wanna make sure that you're not undersizing because you can get rotation. So you just wanna make sure you're properly sized. Patient does great, and this patient is 20/50 uncorrected with a intermediate target. So this patient now has a functional monovision, something that she's never had, and of course, there's videos online of her speaking about her procedure. Another patient here is a patient that comes in with traumatic cataract and severe keratoconus. So this is a young man who had a unclear history of why he had this cataract, but it was pretty dramatic. This was the picture I put in a couple slides ago of a really bad cataract. He was sent to me by another surgeon who said, you know, John, I can't even get calculations. I can't even get a calculation. The keratoconus is so severe. I mean, this is like an 80 diopter cornea or something. And also the cataract is so severe that I can't really do biometry well. I don't know what to do. So we spoke to the patient. He was on board to doing whatever we needed to do to get him better. So we started with the CTAK, and this is a very thick segment. It's about a 500 micron segment because of how severe his keratoconus is. So after the CTAK, he improved to a K max of 61 diopters, and his cornea flattening was pretty impressive already. But he had no visual acuity improvement because he had such a bad cataract. So here is the cataract surgery under the CTAK segment. We used a light adjustable lens here. So you can see here that we didn't use femtosecond laser. I have not done femtosecond laser under CTAK at this point. But we go ahead and we do our incisions. We're doing the capsular excision. This is actually an interesting teaching video because the traumatic cataract involved the capsule. So you had a very fibrotic capsule. So as we're doing the capsule, and you can visualize through the CTAK segment. It actually doesn't affect your visualization terribly. As we're going around here, you're gonna see the capsular excess go out, right there. So I stopped, and instead of proceeding, we basically decided to go around the other way and start making our capsular excess the other way to kind of encapsulate the radialization. So we don't radialize all the way. And again, you can do that with the visualization under a CTAK segment. I don't want anyone to be scared of doing cataract under CTAK. It really doesn't hamper your visualization very much. I would say some of the keratoconics have harder visualization than under a CTAK segment. So we go ahead and finish our rhexis. It's a very soft cataract. This is a young man. He's like 40, 45, 46 years old. And I'm never letting I don't know if we have any problems with the capsule, so we never deflate. We finish our cataract surgery like we normally would. And we have a nice capsule. It's not my most pretty rhexis, but it'll do. And we go ahead and fill the bag again and put in our light adjustable lens, and we're done. So this is a patient that was count fingers, improved to 20/40 postoperative day 1. They were actually a little hyperopic, but we were able to adjust them to getting them to about 20/30 intermediate. And of course, a happy patient able to do his daily living with a very nice recovery. So these are real world outcomes. When we are able to treat the cornea, we can actually get better results ultimately. So what are some of our results? This is our results of phakic IOLs. Okay, so when we do ICLs underneath a CTAK segment. So this is 4 patients, and you can see the results are pretty dramatic. You're going to -13, -7, -20, -6, -9, -13, I mean, these are numbers that when you think about it, they're kind of crazy. And then you get these patients who have outcomes in the 20/40 range, 20/30 range, and able to function uncorrected. And then here are our results for patients that have had cataract surgery or refractive lens exchange under CTAK. Again, really nice results. And we have more patients actually for this category that will hopefully present more soon. But again, with even some of these patients are coming after CTAK and they're realizing that they can actually have good uncorrected vision, and they're requesting refractive lens exchange. They're asking for ways to actually get more visual improvement on top of what they have, which has been pretty exciting and pretty remarkable. So in conclusion, CTAK has become an important treatment for our practice. And now that we have this, we can actually take care of these patients, not only for their cornea, but for their vision rehabilitation. So as a standalone treatment, it's excellent. But then when you add in other modalities along with it, it's a game changer.